Maryam Lustberg, Chief of Breast Medical Oncology, and we are thrilled to be with you here tonight with two of our breast medical oncology experts, Dr. Daniel O'Neill, as well as Dr. Sharynn Hall, who will be giving an update on the latest in all stages of breast cancer. To start with, Dr. Dan O'Neill will present on metastatic breast cancer updates. Dr. Dan O'Neill practices breast oncology in the Waterbury office, and he is a breast specialist focusing on all aspects of breast cancer care. His research focus is on global breast oncology, and I'm very thrilled that he will be giving this talk. Dr. O'Neill?
Hi, thank you, Dr. Lustberg, and thank you to everyone for signing on. It's an impressive sized group for a Tuesday evening. Give me one moment while I pull my slides up. All right, so just like Dr. Lustberg said, I'm going to be speaking about just some updates on new treatments related to metastatic breast cancer, and that is a topic that could really be quite enormous. But in the interest of time, in the interest of having extra time for questions, I'm going to try to provide sort of like a quick overview of newer medications and newer treatments. And then when we get to the portion where we have time for questions, if there are areas people are particularly interested in, hopefully I can talk in a little bit more depth about those aspects. So, let me see here. So as a reminder, when we talk about metastatic breast cancer, what we're talking about is breast cancer that has spread beyond the breast where it originated and beyond any nearby lymph nodes that surround the breast, and really into more distant organs such as the lungs, the liver, potentially the brain, or organs like the bone. Metastatic breast cancer is a less common type of breast cancer. So it can be diagnosed, or it can be, breast cancer can be metastatic at the time of diagnosis, or metastatic breast cancer can be the result of recurrence of a breast cancer that's already been diagnosed and treated in the past and has now come back. Only about 6% of new breast cancer diagnoses are metastatic disease. And then the rates of recurrence vary quite a bit between different types of breast cancer subtypes. And the treatments for metastatic breast cancer really focus on trying to control the cancer. In most cases, metastatic breast cancer can't be eliminated entirely, but the treatments we offer are aimed at trying to help women with metastatic disease live with their disease as well as possible for as long as possible. When we think about the different types of treatments that are available, they tend to break down into different categories based on different breast cancer subtypes. So there are three major breast cancer subtypes. The first one we think about is hormone receptor positive disease. These are breast cancers that are primarily driven by their interactions with estrogen. The treatments, by and large, are anti-hormonal therapies. There are some targeted types of therapies, and then chemotherapies are sometimes part of the treatment as well. The next type of metastatic breast cancer are HER2 overexpressing breast cancers or HER2 positive breast cancers. These are breast cancers that have an overabundance of the HER2 protein on the surface of the tumor cells, the cancer cells. That HER2 protein is involved in telling those cells to grow and to divide in times of stress. And when there's too much of this HER2 protein, it can be a contributor to the cancer's growth. HER2 overexpressing breast cancers, the mainstay of therapy for them are HER2 targeting therapies, of which there are many. And then those are usually given in conjunction with chemotherapies. And then the third type of metastatic breast cancer, the third subtype, is triple negative cancer. That refers to cancers that do not express either of the hormone receptors, the estrogen or progesterone receptor, and don't express an overabundance of the HER2 protein. For triple negative breast cancers, chemotherapies are the mainstay of treatment, the most important component of treatment in many cases. Triple negative breast cancer is one of the few cancers where immune therapies can be effective. And then there are targeted therapies that are available as well. So looking first at hormone receptor positive disease, the initial therapy or the first therapy a woman might take after being diagnosed with metastatic hormone receptor positive breast cancer for some time has been made up of two different types of drugs. The first are anti-hormonal therapies, medications like oral aromatase inhibitors or fulvestrant, which is an injection. And then those are coupled with targeted therapies called CDK4/6 inhibitors, of which there are 3 on the market, ribociclib, palbociclib, and abemaciclib. The CDK4/6 inhibitors work by helping to sort of prevent one of the major mechanisms for cancer cells being resistant to anti-hormonal therapies. And so when they're added to anti-hormonal therapy treatment, they allow women or they prevent progression. They increase the time on that first line of therapy by 40 to 50%. In addition to that, we now know that they also tend to increase overall life expectancy by 25 to 30%. And so that's been standard of care for some time. Some of the newer medications that we think about for hormone receptor positive metastatic breast cancer are drugs that are used in later lines of therapy, second or later lines of therapy. The first one I'll highlight is a medication that's similar to fulvestrant, which has been around for a while. So fulvestrant is a class of medications called an estrogen receptor degrader. It's an injection, and it's a medication that has some but limited activity in women who have a mutation in what's called the ESR1 gene. That is the gene that encodes the estrogen receptor. So the new medication that has come on the market in the last year, got FDA approval in the last year, is an oral medication called elacestrant. It's the same class of drug as fulvestrant, and so it's often when we use elacestrant, it's in place of fulvestrant in most cases. As I said, it's a pill instead of an injection, so it can be more comfortable to receive. And it also has better activity in women who have these ESR1 mutations. They're mutations to the estrogen receptor. In fact, that's what is approved for by the FDA, use in women with an ESR1 mutation. In that group of women, there is about a 45% longer response time or more time on therapy with elacestrant than with fulvestrant. So it works a little bit better as well. The next new drug I'll highlight for hormone receptor positive disease is similar to another drug that's already on the market, epalisib. So epalisib is not a hormone therapy itself. It's more like a CDK4/6 inhibitor. It's combined with hormone therapy and often combined with fulvestrant. It's an inhibitor of a protein called the PI3K protein, and it's specifically approved for women who have mutations in the gene that encodes that protein. It does improve time on fulvestrant, but it comes with some significant side effects, GI side effects, and sometimes hyperglycemia or the development of diabetes. The new medication that works in a similar way is called capivasertib. Capivasertib is also combined with fulvestrant. It inhibits another protein called the AKT protein that's part of the same process, the same signaling pathways in the tumor cell as the protein inhibited by epalisib. And interestingly, capivasertib seems to work, have some activity to work to some extent for women who have cancers with and without mutations in these relevant proteins. And then perhaps even more importantly, it's less likely to cause hyperglycemia, and it's somewhat less likely to cause GI side effects. So it's a drug that's potentially easier to tolerate in place of epalisib. Now, capivasertib has not been approved by the FDA yet. It was sort of designated for accelerated review in June of this year, and so we sort of expect approval will come in the fall or potentially in the winter. I'm going to turn to HER2 overexpressing breast cancers, and here the mainstay of treatment are anti-HER2 therapies. The initial treatment for HER2 overexpressing breast cancer is a combination of three different medications, two of which are these anti-HER2 targeting drugs. The first of those is trastuzumab, which is Herceptin. That's sort of the granddad of all HER2 targeting drugs. It was developed in the 1990s and approved and came to kind of common use in the late 90s, early 2000s. The second anti-HER2 drug in this combination is pertuzumab. That is a similar type of drug that came along a little bit later, also targets the HER2 protein. And those two medications are given in combination with chemotherapy. When trastuzumab was first added to chemotherapy for use in metastatic HER2-positive breast cancer, it increased time until the disease started to grow again by 40%. And then when pertuzumab was added, on top of those two, it increased the time to progression by another 30%. And those have remained the standard of care since the combination kind of came on the scene. Again, some of the newer drugs are drugs that are typically used in later lines of therapy. I'm going to touch on one of those now, and then some of the kind of most exciting new drugs actually are useful across different breast cancer subtypes. So I'm going to talk about those sort of all together at the end of this talk. So if it seems like something's missing, that's why. So the drug I'll highlight right now is called tucatinib. This is an oral anti-HER2 drug. It's a HER2 inhibitor rather than a antibody infusion like trastuzumab and pertuzumab. Tucatinib is used in combination again with trastuzumab and again with a chemotherapy. But when tucatinib is added to those medications, it improves time to progression by about 45%. And it interestingly, it's particularly useful in women who have breast cancer that has spread to their brain or their central nervous system. HER2 overexpressing cancers have a higher likelihood of involving the brain, and so it's important to have good options for women with brain metastases. And the treatment effect of adding tucatinib to trastuzumab and chemotherapy is even a little bit greater in women with brain metastases. The last subtype I'll talk about is triple-negative breast cancer. And again, I'll highlight initial therapies. Now, women who have not been exposed to chemotherapy in the past, who are newly diagnosed with triple-negative breast cancer, chemotherapy is usually the initial line of therapy. And I realize, actually, I don't think I have a slide on this, but triple-negative breast cancer, when it expresses high levels of proteins that signal that it's able to hide from the immune system or evade the immune system, that chemotherapy is given in combination with pembrolizumab, which is one of our newer immune therapies that are more commonly used in cancers like lung cancer or melanoma. There are other cases, though, where targeted therapies, novel targeted therapies, are appropriate for either initial or later line treatment of triple-negative breast cancer. One example of those are a class of drugs that are called PARP inhibitors. So PARP inhibitors work specifically for women who have mutations in the BRCA genes or in some similar genes. They work by essentially taking advantage of the BRCA mutations and the way that the BRCA mutation makes cell division and DNA replication in tumor cells unstable. Those same changes from the BRCA mutation that make cells more liable to turn into cancer, the PARP inhibitors are able to sort of take advantage of those changes and make it so that the cell is essentially acquiring so much DNA damage that it's unable to live, and cancer cells preferentially die off. PARP inhibitors are oral drugs. As I mentioned, they are useful, particularly in women who have received chemotherapy in the past. There's a couple on the market for breast cancer. The first is called olaparib. The other one is called talazoparib. And they work about equally well. So olaparib improves time to progression by about 55% compared to chemotherapy, and talazoparib improves time to progression by about 40%. So they're similar in their effectiveness. So the last type of new medication I'd like to talk about is really more of a group of medications. And as I sort of alluded to earlier, it's a group of medications that is able, in many cases, to cut across different breast cancer subtypes. And to an extent, and I'll explain this, even in some ways redefine how we think about breast cancer subtypes. So that group of medications are called antibody-drug conjugates. So what are antibody-drug conjugates? At their core, antibody-drug conjugates have two, or depending on how you look at it, three kind of key components. The first key component is the antibody. So an antibody is a protein that is typically made by your immune system that is designed to target a specific other protein target. And so your immune system makes antibodies against proteins that appear to be from infectious sources, bacteria or other kind of foreign substances. Many of the cancer drugs that we use now are antibodies that have been developed by scientists because they target proteins on the surface of cancer cells. Trastuzumab is an example of one of those types of antibodies. What makes antibody-drug conjugates different from all of the other targeted antibody anti-cancer drugs that have existed up until this point is that in addition to the antibody and fused to that antibody are individual molecules of high potency chemotherapy. So these are chemotherapies that would be too toxic to give directly, like systemically through an IV, but when they're delivered in kind of small doses in a very targeted way by the antibody to which they're bound, they can be highly effective. So how that works is sort of captured in this cartoon here. You sort of see up in the upper left corner, the antibody-drug conjugate has been attracted to this protein on the surface of the cancer cell. The cell then sort of engulfs or swallows the entire complex. It breaks down the complex into its sort of individual parts inside of what's called a lysosome in the cell. And by breaking it down, it releases the chemotherapy payload, which is now inside the cell and is able to hopefully kill the cell. The first one relevant to breast cancer that I'll describe is called sacituzumab govitecan, or the brand name is Trodelvy. So this is an antibody-drug conjugate or I should say this is an antibody. The sacituzumab is an antibody that targets the TROP2 protein. The TROP2 protein is a protein that's on the surface of about 80% of breast cancers. That is true across different breast cancer subtypes. And then the chemotherapy bound to sacituzumab is called govitecan. That is a chemotherapy that's similar to the drug irinotecan, which we don't really use for breast cancer very often. Trodelvy was first studied and approved for triple-negative breast cancer for women who had already had initial chemotherapy treatments. And when it's compared to just further lines of chemotherapy, it improves time to progression by 60%. So it works quite well. And in many cases, it's also better tolerated than traditional chemotherapies. After it was studied and approved for triple-negative breast cancer, it was also studied for hormone receptor positive breast cancer. In this case, for women who have already taken anti-estrogen medications, some of the ones I showed earlier, and compared to just typical chemotherapy, sacituzumab improved time to progression by 33%. So there's activity in multiple different types of breast cancer. So the last drug I'm going to talk about is exciting for a few different reasons. So this is trastuzumab deruxtecan. This is a drug I mentioned that sort of, to some extent, will or redefines how we think about breast cancer subtypes. The brand name is Enhertu, and it's made up of an antibody, trastuzumab. You'll remember that that antibody is the Herceptin antibody. It's the same antibody essentially as the antibody that is the drug Herceptin, and so it targets the HER2 protein. The chemotherapy attached to it is called deruxtecan, another chemotherapy similar to irinotecan. And so when HER2 was developed, the obvious place to use it, first place to use it was in HER2 overexpressing breast cancers. When it was studied as the second line therapy, a therapy used after that combination of 3 drugs I showed at the start, it improved time to progression compared with the existing standard of care by 75%. So there was a big improvement. It worked really well in that setting. What makes it unique, though, is that because of some of the way that deruxtecan is able to move across cell membranes fairly freely, and HER2 actually has what's described as a bystander effect, meaning that the chemotherapy that it carries has an impact on the cells that it targets, but it also has an impact on the cells that are next to the cells that it targets. It's able to kill cells that are next to its target. So why is this important? When we describe breast cancers, typically their HER2 status, we talk about them being HER2 positive or HER2 negative. But in reality, really HER2 expression exists on a spectrum. Almost all breast cancers express some amount of the HER2 protein. And what we've been calling HER2 positive is really more breast cancers that have a medium to high amount of the HER2 protein. But lots of the cancers that we describe as HER2 negative have low to medium amounts of the HER2 protein. So because of these low levels of the HER2 protein that in the past have not been enough for anti-HER2 targeting drugs to be effective. Essentially, there are lots of cells, breast cancer cells, without the HER2 protein that are unaffected by the HER2 targeting drug. And so those HER2 negative cancers weren't sensitive to HER2 targeting drugs. With the bystander effect associated with the HER2 and the deruxtecan chemotherapy, there actually is an ability to take advantage of that HER2 target, even in patients who have low amounts or what would have previously been considered HER2 negative breast cancers. And so this has been studied using Enhertu for HER2 low expressing breast cancers, and compared with just typical chemotherapy for HER2 low breast cancers, Enhertu improved time to progression by 50%. It did a lot better than typical chemotherapy and has pretty quickly come into common use for these HER2 low breast cancers. So those are all the new drugs I'll talk about. The very last thing I'm going to show is I just want to highlight that a lot of the new medications, really all the new medications I mentioned, came out of clinical research, and clinical research is ongoing. At the Cancer Center, we have a variety of clinical trials. I can't possibly talk about all of these right now, but I just want to kind of get across the message that there are a lot of different options for not just the medicines we spoke about, but also new and emerging medications as well. So with that, I'll stop, and I'm happy to take questions now or questions at the end, or whatever is easiest.
Thanks, Dr. O'Neill. As to our audience, as you're listening in, feel free to put your ongoing questions in the question and answer chat box, and we're happy to address them either by directly writing into the chat, and some of them we'll take verbally at the end of the presentations. For Dr. O'Neill, just a quick question to kind of wrap up your section in terms of, you mentioned a lot of different targeted therapies and emerging therapies. Kind of maybe just kind of a message to the audience in terms of being aware of their many options as they undergo treatment throughout the cancer continuum of care. Just maybe kind of additional message in terms of awareness of tumor biology. If you could just kind of speak on that a little bit more.
I'm sorry.
Just I guess knowing your tumor type and knowing the biology of the tumor, kind of that would be like a really important takeaway from your talk that I would love for you to just kind of briefly.
Oh yeah, well, so absolutely. I mean, fundamentally, it's essential to have a good understanding of your breast cancer subtype, like the estrogen receptor and HER2 status. That's fundamental. There are other aspects of tumor biology that kind of fall outside the scope of those descriptors. There are individual mutations that can occur in tumor cells. Some of the things I highlighted, like ESR1 mutations, which can impact which sort of drugs you might be eligible for, or mutations to the AKT pathway that might impact whether or not certain drugs are effective. These are things that we investigate with sort of higher level testing and things that we check on an ongoing basis. Actually, one interesting sort of bit of evolution maybe in how we think of breast cancer subtype as well is that with the emergence of an options for HER2 low breast cancers and HER2 specifically, I think that more and more providers are finding that it can be useful and important to not just biopsy a cancer once at the start of treatment and then sort of treat based on that initial biopsy for the entire time that you're undergoing treatment, but actually to reconsider periodically, particularly when things are behaving in an unexpected way or when you're considering new treatment, to consider rebiopsying. There was interesting data from a group at Massachusetts General Hospital that was presented this past summer, suggesting that there can be significant changes in HER2 status over time as if a cancer is biopsied several times, over a period of months or years, and women who might have been HER2 non-expressing can sometimes become HER2 expressing or have HER2 expressing parts of their cancer that weren't seen previously. And that can change how we think about therapy as well.
Great. We have a couple of questions on the chat that we can take for a few minutes before moving on to the next presentation. One is kind of what fuels hormone receptor negative tumors, kind of what is driving these tumors, if not estrogen, what else? And then I'll take the next question after you guys.
Sure. So hormone receptor negative tumors are typically not really fueled strongly by estrogen. Sometimes there's a kind of clear, demonstrable thing that is responsible for their growth or largely responsible, like the HER2 protein. An overabundance of the HER2 protein can be a major driver in a cancer's growth. And then with triple negative breast cancers, it's a little bit more of an amalgamation. There are all sorts of different mutations that you can have in the pathways that, or in the proteins and the processes that control appropriate growth, healthy growth, versus when it's appropriate for a cell to die instead of to survive, when it's appropriate for a cell to stay where it originated instead of moving into local tissue or into distant areas, and those processes can become mutated, and there may not be a sort of chemical that drives the cancer's growth in the same way we think about estrogen, but it's really more of a sort of dysregulation of the normal processes that control and manage growth in the cell.
Thank you so much. And then one last question before we move on is related kind of to breast cancer being a metabolic disease that uptakes glucose and glutamine, and what else you can say about that.
Yeah, I get this question from patients a lot. And I think it's an area of research that is where the full story is not really told yet. Um, Cancers definitely use more glucose and more energy than healthy tissue. That's essentially how things like PET scans work by taking advantage of looking for areas of the body or tissues that are using more glucose than the surrounding areas. Um, Now, whether or not that fact kind of can be translated into the idea that you could reduce the risk of developing a breast cancer or treat a breast cancer that you've already developed by minimizing sugar or having these very low glucose diets, I think that's less clear based on the research that's been done so far. I generally do not recommend to patients that they go onto a very low sugar diet. There's nothing wrong with following a heart healthy diet high in fruits and vegetables, low in processed carbohydrates, but diets that completely eliminate sugar, I'm not convinced myself that those make a big difference in breast cancer outcomes.
Thank you so much, Dr. O'Neill. Moving on to Dr. Sharynn Hall, who is also one of our trusted colleagues in the Breast Medical Oncology Division. Dr. Hall sees patients in both the Torrington and Waterbury offices, and she'll be talking about early stage breast cancer. Dr. Hall, feel free to share your screen.
Okay, can everyone hear me?
Yes, you're all great.
Great. So good evening, everyone. It's a pleasure to be here with you tonight. I wanted to spend this time and focus on a question that I encounter on a daily basis in the management of early stage breast cancer. And that question is do I need chemotherapy? So my talk is entitled Chemotherapy, Why? The answer is not always very straightforward because there are multiple considerations. I would like to use this opportunity to walk through some of the clinical scenarios that would warrant systemic chemotherapy and also overview some of the clinical tools that we use to determine who needs systemic chemotherapy. So this is Breast Cancer Awareness Month, and this slide shows some of the relevant statistics about the disease. Breast cancer is the most common cancer in women in the United States. There are close to 300,000 new cases anticipated in 2023, and this is data from the SEER database. Breast cancer represents approximately 15% of all new cancer cases, and over 43,000 individuals with breast cancer are predicted to die from the disease in 2023, and this represents approximately 7% of all cancer deaths. Despite these statistics, the 5-year relative survival for breast cancer is upwards of 90%. Now, breast cancer management is multidisciplinary. It begins the moment an abnormality is identified on screening mammography or on physical exam. The management of breast cancer pulls together the expertise of multiple disciplines from radiology, pathology, breast surgery, medical oncology, and radiation oncology. And they collaborate to identify the best plan of care for you. This is a patient-centered approach which takes into consideration your concerns and your circumstances. And the goal here is to deliver the best outcome with minimal toxicity. So there are three general pillars in the management of breast cancer. Most often, there will be a surgical resection of the disease, usually a lumpectomy, in which the portion of the breast containing the cancer is removed. The surgery might be a mastectomy, in which the entire breast is removed, or addition, there might be some lymph node sampling. Under certain circumstances, additional therapy is warranted after surgery, mostly to improve risk from disease relapse. There might be consideration for radiation therapy if a lumpectomy was performed, or in other cases where there was a large burden of disease at presentation. The amount of radiation is carefully prescribed to limit the toxicity to adjacent areas. Most often, you will also meet a medical oncologist who coordinates the management of systemic therapy. Systemic therapies include oral agents like tamoxifen, anastrozole, letrozole. These are endocrine therapies that are utilized in estrogen-sensitive tumors. Chemotherapy is another form of systemic therapy that's usually given intravenously, and these formulations are designed to sicken the cancer cells so that they do not survive. The decision to deliver chemotherapy is not always easy and takes many factors into consideration, including your preference. Now, there are some benefits to chemotherapy, despite the fact that chemotherapy administration is often viewed negatively. The benefits are not necessarily, there are benefits of that chemotherapy offers that are not necessarily achieved with other treatment modalities. For instance, chemotherapy will reduce the burden of disease when at presentation there's a high burden of disease. In most cases, the addition of chemotherapy is used because clinical trials have shown some benefit in disease-free survival or overall survival. In short, there may be greater longevity with the use of chemotherapy. There are cases in which chemotherapy response is used to guide additional systemic therapy in the adjuvant setting. And lastly, chemotherapy is usually utilized to reduce recurrence risk. Some disadvantages of chemotherapy include the toxicities. There are short-term toxicities that affect the gastrointestinal tract that include things like nausea, vomiting, bowel changes, changes in appetite. There's fatigue, there's the hair loss, there's weight loss, and then there's financial toxicity related to the inability to work. Long-term toxicities often include chronic peripheral neuropathy from taxane-based chemotherapies. Chronic hair loss can also present. Cardiotoxicities associated with anthracycline-based treatments, and also Herceptin or HER2-mediated targeted therapies. In addition, long-term financial toxicities can exist. People can lose their jobs, lose their homes, or lose other sources of financial support. And secondary malignancies like leukemia are some of the rare long-term toxicities related to administration of chemotherapy. Clearly, there is an ongoing effort by researchers, medical oncologists, and physicians in general to balance the risk of these toxicities against the benefits and the goals of therapy. The trend forward is to de-escalate these therapies in order to reduce the toxicity burden and develop clear criteria as to which individuals would benefit from systemic therapy. And so what follows are some of the factors that we take into consideration when we decide to administer chemotherapy. So some decision-making factors include molecular subtypes, an entity called genomic risk score, whether or not the cancer is locally advanced or inflammatory, the hormonal status of the patient, the age of the patient, and lastly, or even firstly, patient preference. Now, molecular subtypes refers to groupings of breast cancers based on gene expression profiles that in part predict the biology of the breast cancer. This research has led to three main groupings: breast cancers that express estrogen receptors or progesterone receptors are hormonally responsive breast cancers. In this diagram, they are represented by the classification of luminal A and luminal B subtypes. Breast cancers that express an abundance of a protein called HER2/neu are known as a HER2/neu or HER2-enriched subtype. Irrespective of the presence or absence of estrogen or progesterone receptors, these groups are known to have a worse prognosis than the luminal A and luminal B subtypes. The last subtype group is breast cancers that do not express estrogen receptors or progesterone receptors or HER2/neu. And we will talk more about these subtypes as we go forward. And this last subtype is called triple negative breast cancer. And this graph is from the SEER database, and it represents the distribution of breast cancer subtypes among new breast cancer cases. And as you can see, the majority of cases are hormone receptor positive, representing approximately 69% of cases. The HER2/neu enriched and triple negative subtypes make up the remaining 30% of cases. This slide shows the 5-year relative survival for the different cancer subtypes. So one might ask, how does the subtypes factor into the administration of chemotherapy? Now, based on this graph, we're looking at the 5-year survivals. We can clearly see that the best outcomes are demonstrated in the hormonally sensitive subtypes that express estrogen and progesterone receptors. And they show basically a 94.8% 5-year survival. The worst outcome is demonstrated in the triple negative group that does not express either of the three proteins. And this shows a 77.6% subgroup. There is another subgroup on this graph titled unknown, which likely represents a poorly differentiated histology, in which case they're not able to delineate very well which subgroup it fits in, but most likely it mirrors that of the triple negative breast cancers. And then in the middle, the HER2 enriched subtype has an intermediate 5-year survival between 85% and 91% based on the presence or absence of estrogen and progesterone receptors. So let's take a look at these subtypes. Hormone receptor positive breast cancer is the most common subtype with the most favorable survival statistics. Despite this, this subset is known to have the risk for distant relapses, sometimes 10 to 20 years after the initial treatment. Patients in this subgroup are primarily managed with endocrine therapies, but there are instances in which chemotherapy might be indicated to reduce the risk of predicted disease recurrence. Now, there are two known FDA-approved genomic risk assessment tools that help determine if there is a chemotherapy benefit in the population of patients with hormone receptor positive disease. These tests basically predict the risk for breast cancer recurrence. The Oncotype DX is also known as the 21 gene risk recurrence score assay, and it's designed for patients with early stage hormone receptor positive disease. It assesses the surgically excised tumor specimen for the expression of these 21 different proteins indicated in these boxes. And based on the results, a recurrence score between 0 to 100 is calculated. A high recurrence score is usually an indication for the need for systemic therapy. Similarly, MammaPrint analyzes tumor specimens for a 70 gene signature. So instead of 21, it's looking for 70. The results are similarly able to stratify patients with stratify patients into high versus low risk groups. Concordant high clinical risk and high genomic risk groups are known to warrant chemotherapy. The HER2 positive breast cancer subtype is known as an aggressive subtype. And when we say aggressive, that usually means it's fast growing and has a tendency to metastasize at an early time frame. The HER2 enriched disease shows a greater prevalence for younger patients, and despite being biologically aggressive, newer targeted therapies such as Herceptin and Perjeta have mitigated the negative outcomes associated with the overexpression of the HER2 protein. Tumors that are larger than 2 centimeters or T2 or higher are often treated preoperatively with targeted HER2-directed therapy. And this therapy is usually given in combination with chemotherapy. The response to this therapy is often used to gauge the need to change the treatment protocol in the adjuvant setting or to continue with the same medications. Some of the setbacks with this subtype includes the possibility for reduced responsiveness to the HER2-directed targeted therapy. And another drawback is the development of cardiotoxicity related to the targeted therapy use. Triple-negative breast cancers, these are breast cancers that do not express estrogen receptors, progesterone receptors, or HER2/neu, are the most aggressive subtype. They're not homogeneous, but it's a heterogeneous group. It represents 10 to 15% of all breast cancers. There's a higher prevalence in younger women, women who carry the BRCA gene mutation, and women of African American descent. Similar to the HER2 subtype group, treatment of this subtype group is often in the neoadjuvant setting with chemotherapy, and the response to therapy dictates the need for treatment in the adjuvant setting. Other instances in which chemotherapy might be beneficial is in the treatment of locally advanced breast cancer. Locally advanced breast cancers represent 5% of newly diagnosed breast cancers and is associated with a cancer-specific mortality of 43%, as well as a high relapse rate. Because of this, these women benefit, irrespective of the subtype, from benefit from systemic chemotherapy. Now, locally advanced breast cancers are defined as tumors with disease with a significant burden in the breast, significant involvement of the axillary lymph nodes, an inflammatory appearance of the breast, or no evidence of metastatic disease. So the intent here is to give these patients who present with very advanced regionalized breast cancer upfront chemotherapy to shrink the disease, and that allows for a better operative and cosmetic outcome, and it also helps with the disease survival overall. Independent risk factors for breast cancer include age and hormonal status. And I just include this because women who are younger than age 50 tend to have a more aggressive course of disease. It is estimated that 7% of all breast cancers occur in women who are younger than 40 years of age, and 4% occur in women younger than 35 years of age. And historically, this cohort has breast cancers that are associated with poor survival. These patients are primarily premenopausal. The breast cancer is described, biology is described as aggressive, and usually is an aggressive subtype like the HER2 enriched or triple negative. These patients usually present with a more advanced stage disease, so locally advanced disease. Their disease, due to being more aggressive, is also at a greater risk of relapse. It's possible that other factors that include breast density, familial genetics, such as an association with the BRCA gene mutations, or pregnancy status, impacts the overall presentation of this disease in premenopausal women. And this is why these women greatly benefit from chemotherapy. Now, I've walked through some of the factors that we take into consideration when we administer chemotherapy and recommend chemotherapy in early stage breast cancer. The goal in systemic therapy in early disease is risk reduction. And so I thought it also important to leave you with some other risk reduction modifiers that are important in the war on breast cancer. And so these are some NCCN guidelines with regards to risk modifiers, lifestyle modifiers. It's important to understand that alcohol intake increases the risk for breast cancer, and NCCN guidelines recommend no more than 3 per week. Exercise, it's important to be active on a daily basis. 150 to 300 minutes of moderate intensity physical activity helps with the reduction of breast cancer risk. And lastly, weight control also helps reduce breast cancer risk. I hope this information has been useful for you. Thank you.
Thank you, Dr. Hall, and thank you for our audience who have been troopers sticking around on a Tuesday night. We're happy to take questions in the last remaining minutes in our open question and answer. Dr. Hall, kind of while we're waiting, I think you did a really nice job kind of wrapping up with health promotion aspects of breast cancer care, which I think all of us could absolutely talk more about. So thank you for mentioning that for sure. Let's see, any questions? I know we're pretty close to time. Thank you everyone for joining. Just know that you can also reach out. Oh, there are, yes, we will have the presentation as well as the video recording made available to you all. So thank you for that interest, and really glad that you guys joined us. And just know that we're all available as a resource throughout the Yale network, and we're really happy to support you all, whether it's October or any other month of the year. Thank you so much.